Hi guys, it's me again, Dr. Brian Litworth, and today we're going to talk about the drug treatment of airflow obstruction. So you should have looked at the previous lecture overview of airflow obstruction before you look at this one, just in case you haven't. So here are the key words, learning objectives, look at those at your leisure. Drugs for airflow obstruction can be divided into those which are anti-inflammatory, which we call preventers or controllers, the two are synonymous, and bronchodilators, which are called relievers. You've already seen this slide, the inflammatory cascade in asthma, which I've gone through, but I'll just repeat it again, that when we're treating asthma, which is what we're talking about first of all, that the key is to damp down the cascade from the top in terms of using anti-inflammatories, melting away eosinophils with corticosteroids, which prevents the bottom of the cascade from occurring. So the aim should be to treat patients with inhaled steroids so that they don't need reliever therapy with short-acting beta agonists. This slide shows the relationship between type 2 inflammation and biomarkers in asthma. And I don't want you to learn this, it's really just for information purposes only, because it shows you the relationship of the key Th2 cytokines, IL-4, 5 and 13, in relation to type 2 biomarkers, namely IgE, exhaled breath nitric oxide, and eosinophils. But it's really for information purposes, and you can look at that and read the article if you've got nothing better to do, or if you're having trouble getting to sleep at night. I can thoroughly recommend it. This is a slide I devised called the asthma treatment pyramid, which shows you the different drugs that we use to treat asthma against increasing severity. So mild patients at the bottom, severe patients at the top. And the reason I did this is it feeds neatly onto the slide. So at the bottom of the pyramid, you've got just using short-acting beta agonists alone. So these are patients who just might use them intermittently for, say, relief of exercise-induced bronchoconstriction if they're going to the gym, who don't have persistent symptoms. Anything in the way of persistent symptoms needs a first-line controller, namely an inhaled corticosteroid, and then we can adjust the dose of inhaled corticosteroid against symptoms, reliever use, and lung function. Those are the titration markers, and we can also use exhaled breath nitric oxide and eosinophils. If they're not controlled on an optimized dose of inhaled steroid, then we can add in a second-line controller, and that can either be a long-acting bronchodilator, like a long-acting beta agonist, LABA, or a long-acting muscarinic antagonist, LAMA, or both, in a triple inhaler. Or we can add in a second-line anti-inflammatory, like a leukotriene receptor antagonist or theophylline, and we'll go into those in more detail. And then finally at the top, although we can use oral steroids, corticosteroids like prednisolone for short bursts, we shouldn't use them for long-term treatment. And the reason for that is that we now have biologics to damp down the type 2 inflammatory cytokines, which are steroid sparing. So we shouldn't use oral corticosteroids long-term. If we're going to damp down the type 2 cytokine profile, we should use specific biologics instead. Key learning point there. These are the GINA, the Global Initiative guidelines for the management of asthma. And a couple of points I want to make. Firstly, that as you can see, inhaled corticosteroids are the spine all the way through the treatment steps. So you take an inhaled corticosteroid and then you add on either a LABA or a LAMA or a leukotriene receptor antagonist. That's really all you need to know. Don't need to learn that, it's just for information purposes. And the British Thoracic Society guidelines and NICE guidelines are pretty much the same. So let's just delve into each of the drugs now in more detail. We'll start off with the anti-inflammatories and we'll talk about the corticosteroids, also known as glucocorticosteroids. So these, your own body produces its own natural corticosteroid, which is cortisol, which it produces from the adrenal cortex in response to stress. That's your own body's natural glucocorticoid, cortisol. Corticosteroids are used in both conditions, asthma and COPD. They can occasionally cause pneumonia in COPD, and the reason they do that is because they, as well as damping down the eosinophilic type 2 inflammation, they can also produce local immune suppression, and in the presence of impaired mucociliary clearance and altered microbiome in COPD, that can promote pneumonia. It doesn't tend to be the same sort of problem in asthma, pneumonia, it's more in COPD. Oral steroids are synthetic analogues of cortisol. The one that we use is called prednisolone. In America, they use a drug called prednisone, which is a prodrug. It's metabolized to prednisolone. It has a low therapeutic ratio. In other words, the dose which gives you the therapeutic efficacy in melting away eosinophils is very similar to the dose which gives you corticosteroid-like side effects. So corticosteroid-like side effects in long term would be things like basically the effects of cortisol in excess. So there'd be things like putting on weight, fat deposition, diabetes, hypertension, cataracts, proximal myopathy, tendon ruptures, that kind of thing. And of course, immunosuppression with opportunistic infections with things like candida causing candidiasis. They're only used for short bursts because they do have a low therapeutic ratio. So they're used for acute exacerbations of asthma or eosinophilic COPD, but they're not used for long-term maintenance. I want to make that clear. So you might give them for a week or two in the face of an acute exacerbation, but you wouldn't give them long-term. I should also emphasize that the biologics, the type 2 biologics, they're only licensed for asthma. They're not licensed for COPD. Let's get that clear. We don't use biologics for COPD because they've been proven to be ineffective. The archetypal inhaled corticosteroid is beclomethasone dipropionate, or BDP. It's been around for probably, 40 years now. It was certainly around when I went into medical school in 1977 to St Andrews. It has a high therapeutic ratio. In other words, the dose of inhaled steroid, which suppresses inflammation, is much higher than the dose which gives you systemic effects. So although you do get dose-related systemic effects like prednisolone, you only see that at much higher doses. And in that case, the systemic effects are much less than you would see with prednisolone. And that's because you're delivering the drug directly to the site of action, what we call local drug efficacy. It's going straight to the lungs, okay? So for example, you would give 40 milligrams of prednisolone to treat acute asthma, whereas for persistent asthma, you would probably use 0.4 milligram, which is 400 micrograms. So that's a 100-fold difference in dose. And that's because beclomethasone is more potent, number one. Number two, it's going directly to the site of action. Whereas with a systemic drug, you have to take it, it goes into the bloodstream and it's distributed around the body. Inhaled steroid can either be used on its own or in combination with LABA or LAMA, long-acting bronchodilators in asthma, but it's only used in combination with LABA or LAMA in COPD. It's never used on its own as monotherapy. It doesn't have a license indication, and that's because it's not as effective. They reduce exacerbations in eosinophilic asthma and in eosinophilic COPD, otherwise known as asthma-COPD overlap syndrome. So it really only works in eosinophilic disease. Most patients with asthma are eosinophilic. Only a small proportion of patients with COPD are eosinophilic. And the key is to try and optimize lung delivery, get it as deep into the lung, into the peripheral airways. And the ways you can do that is to use a spacer device or to use what we call an extra fine solution hydrofluoroalkane formulation of the drug, which has got very small particles in the order of about 1 micron. So basically, to get past the carina, you need particles smaller than 5 microns. So all of the inhaled drugs have a particle size less than 5 microns. The smaller the particle size, the more peripheral the lung delivery. So this is what's known as a corticosteroid reversibility test. We don't really do this anymore. You can see it's a very old slide from the reference, but it illustrates a nice point. So this would be a patient with poorly controlled asthma. You might then give them a couple of weeks of prednisolone, 40 milligrams a day. You can see their average peak flow improves, and you can see the amplitude, the diurnal variability of the envelope also is reduced. And then you switch them to beclomethasone in a dose of 0.4 milligrams a day, 400 micrograms, and you maintain the same response that you got with prednisolone. So you induce remission with oral steroids and you maintain it with inhaled steroids. You never use inhaled corticosteroids for treating acute unstable asthma. Key learning point there. This is just a conventional press and breathe metered dose inhaler. So you press it and then the aerosol comes out at about 100 kilometers an hour. The problem with these metered dose aerosols or MDIs is that the aerosol then impacts on the back of the throat, the oropharynx, and makes the patient gag, and then they stop breathing in. The way around that is to use a device known as a spacer, which is just a plastic holding chamber. This is a 150 mil spacer known as an aero chamber. This is a 750 mil, so is this one. These are all made by different manufacturers to fit different inhalers. This one here, the aero chamber, is universal and fits all inhalers, and that's the one we tend to use now. It's obviously less cumbersome than carrying one of these around in your pocket. So this end here goes into the rubber orifice, and then you press the actuator in, and then the aerosol bombards around the walls of the spacer, which makes the particles smaller and go slower, and then you can inhale in deeply into your lung. So the actions of a spacer is that it avoids the coordination problem of pressing and breathing in, because you're using the spacer as a sort of a holding chamber. So it's much easier to coordinate, pop it into the spacer, and then you breathe in your own time. There's not that mad rush for actuation inhalation. It reduces local side effects in the oropharynx and the larynx from inhaled steroids. Inhaled steroids can cause local mucosal suppression and give you oropharyngeal candidiasis, and can also deposit on the vocal cords, giving laryngeal candidiasis, or you can get atrophy of the muscle in the vocal cords, giving you hoarseness. So what happens is the spacer acts as a false oropharynx, so the large particles, more than 5 microns, get stuck in the spacer, and the small particles are inhaled into the lung. At the same time, by reducing the large particles which stay in the spacer, you reduce systemic absorption from the fraction which is swallowed with inhaled steroids. So instead of swallowing it, it gets stuck in the spacer, so it's a win-win. As I've already said, it acts as a holding chamber for the aerosol, and when the particles bombard on the wall of the spacer, that reduces particle size and velocity of particles, which are smaller and travel slower, go deeper into the peripheral lung. And consequently, it improves lung deposition. So you might ask, if you're using a metered dose inhaler, why wouldn't you use a spacer? And you'd be absolutely right. And that's why whenever I prescribe any metered dose inhaler, whether it be a preventer or a reliever, I only ever use it through a spacer device. I would never use a metered dose inhaler alone. These are alternatives. These are dry powder inhalers, quite old-fashioned ones. I should really update this slide. This is a dry powder inhaler made by AstraZeneca called the Turbohaler. And this fella here is made by GlaxoSmithKline, which is called the AccuHaler. They've now brought out a later version of this, which is called the Ellipta, which looks pretty much the same, to be honest with you. So all of the GSK drugs are delivered through the Ellipta platform, and all the AstraZeneca drugs are delivered through this platform here, the Turbohaler. So what you do with this Turbohaler, dead simple, you just turn the handle there, which then actuates, deaggregates some drug, and then you take a deep breath in, and that basically means you can inhale the drug directly into the lung, so it's breath actuated. So it's much easier to use, and there's a weak counter on there as well, as there is on the GSK device. Dry powder inhalers tend to be more popular for younger patients because you don't have to carry the spacer around. And the beauty about the dry powder inhalers, because they are breath actuated, is they avoid the problem with inhalation actuation. Now, actually, just to complicate matters, you can actually get metered dose inhalers now, which are breath actuated. So examples of that would be the Easy Breathe device, which is quite a nice device for delivering preventers and relievers. That's one way of using a metered dose inhaler without a spacer, is to use a breath actuated MDI like the Easy Breathe. So we've done corticosteroids, we've done delivery. Moving on to another anti-inflammatory, albeit less potent, are the chromones. The archetypal chromone is sodium chromoglycate, which was around even in the, I think the late 60s, 1970s. I think it came before the corticosteroids actually. It's a weaker anti-inflammatory compared to, say, inhaled beclomethasone. It stabilizes mast cells predominantly, doesn't do anything to eosinophils. It's effective in allergic patients, and it's also effective at preventing exercise-induced bronchoconstriction. So if you've got a child, an allergic child who's got an exercise component, it's useful. We'd never use a chromone on its own. We'd only ever add it to an inhaled corticosteroid. It's not an option to inhale corticosteroid. It's only used as second-line add-on controller therapy. It's given by the inhaled route. The problem is it's short-acting, so you've really got to give it 4 times a day through a spacer, which is a bit of a pain. To be honest, it's really not used much now due to poor efficacy. I might use it as add-on to inhaled steroid in an allergic patient who's got an exercise component that's not controlled on other more routine first and second line controller therapy. We're going to talk about anti-leukotrienes. This is the leukotriene biosynthesis pathway. I'm not going to spend much time going into this. Basically, you have membrane-bound phospholipid, which is broken down into arachidonic acid that can go either through the cyclooxygenase or lipooxygenase pathway. If it goes through the cyclooxygenase, it produces prostaglandins and thromboxanes involved in pain and blood clotting with platelets. If it goes down the 5-LO pathway, it produces leukotriene A4, which then goes to C4, D4, and E4. So the main cysteinyl leukotriene, well, there's C4, D4, and E4, but the main one is leukotriene D4. That's what the leukotriene antagonist block, and the archetypal drug is called montelukast. And these have been around now for, over 20 years. Leukotriene D4 has many actions. It is a chemotactic to eosinophils. It's produced from inflammatory cells like mast cells and eosinophils, and it then sucks the inflammatory cells back into the site. It sensitizes the smooth muscle, makes it constrict and proliferate. It causes leaky blood vessel to produce edema. It promotes mucus secretion and impairs mucociliary transport. So you can see these are all important pro-inflammatory mechanisms. So blocking leukotriene D4 should help your asthmatic inflammation. They're only used in asthma, they're not used in COPD. Montelukast is an oral tablet given once daily with a very high therapeutic ratio. It's even given down to the age of 2. It's less potent than an anti-inflammatory as inhaled steroid, and it's never used on its own instead of inhaled steroid. It's only used as add-on therapy to inhaled steroid. So if you've not got control with inhaled steroid, you might add on montelukast, or you might add in a long-acting beta agonist, a second-line controller therapy. Good news is that montelukast is very effective in exercise-induced bronchoconstriction, and it's used in most elite athletes as second-line add-on to inhaled steroid for that very reason. It's probably the best drug for treating exercise-induced bronchoconstriction asthma. It's also effective in allergic rhinitis, particularly so when it's given with an antihistamine. So if we had a patient with allergic asthma who also had allergic comorbidity with allergic rhinitis, we'd probably add in montelukast with an antihistamine like, for example, ketorolac. This next slide is something we just published recently in the Journal of Allergy and Clinical Immunology and Practice, just to show you the role of type 2 inflammation with asthma. So these are the biomarkers, IgE, exhaled breath nitric oxide, FeNO, and peripheral blood eosinophils. That's what we measure. in the clinic, which results in asthma, and that manifests as either exacerbations or symptoms, mucus production, not as big a problem as in COPD, airway hyperresponsiveness, and it also sensitizes the airway smooth muscle to become twitchy. Also bear in mind type 2 comorbidities, chronic rhinosinusitis with nasal polyposis, atopic dermatitis, allergic rhinitis, and eosinophilic esophagitis, and chronic idiopathic urticaria. I don't expect you to learn that, it's just for information. You should probably know about the biologics, but you don't need to know much about them, you just need to know they exist and the three classes, which are anti-IgE, which blocks IgE, as it says on the tin, drugs which block IL-5, which can block either IL-5 itself or the IL-5 receptor, or drugs which block interleukin-4 receptor. We'll start off with anti-IgE, so these are anti-inflammatory, blocking the type 2 inflammatory process. These are all monoclonal antibodies, which is why they all end in MAB. There's the clue. So this was the first kid on the block, the first biologic for asthma, omalizumab, which goes by the trade name of Xolair. It inhibits binding to the high affinity IgE receptor, inhibits the Th2 response and associated mediator release from basophils and mast cells. It's an injection given every 2 to 4 weeks, depending on body weight, only used for asthma, and it's only used for severe persistent allergic asthma, those with a raised total or specific IgE. That, in other words, despite maximal therapy at step 4. So your patient's already on inhaled steroid, maximum dose, already on probably LABA and LAMA, maybe a leukotriene receptor antagonist. They're bouncing on and off courses of prednisolone. That would be the sort of patient we're talking about. They're very expensive, but all biologics are. They tend to have little effect on pulmonary function like FEV1 or peak flow, but they do reduce exacerbations and they do confer an oral steroid sparing effect. So we mainly give them to reduce exacerbations. That's the main indication. So patients who are bouncing on and off oral prednisolone throughout the year. The next example would be those that block interleukin-5 or the interleukin-5 receptor. The drug which blocks the IL-5 ligand is called mepolizumab, and the drug which blocks the receptor is benralizumab, which go by the name of Nucala and Fasenra, respectively. So interleukin-5, as you know, is a come hither for eosinophils, so this melts away eosinophilic mucosal inflammation in asthma and in the blood. It's an injection given every 4 to 8 weeks, depending on which drug you give. It's for patients with severe step 5 refractory eosinophilic asthma. So this would be patients with blood eosinophils more than 300 cells per microliter, more than 0.3 times 10 to the 9. Very expensive, like anti-IgE. And like anti-IgE, they mostly reduce exacerbations and allows us to get to stop patients going on to regular maintenance prednisolone. Tend to be more effective at reducing exacerbations than IgE. So if you've got a patient who's allergic and eosinophilic, you'd probably put them on anti-IL-5 rather than anti-IgE because it's more potent. And the new kid on the block, which has a license but hasn't been approved yet by the Scottish Medicine Consortium, or NICE in England, is anti-IL-4 receptor alpha. And these block signaling downstream of interleukin-4 and 13. The archetypal drug is dupilumab. That's the only one at the moment. It's an injection given every 2 weeks, only for asthma. None of these biologics are used for COPD. They haven't been proven to be effective thus far. These, again, are for patients with step 5 refractory severe asthma with either raised blood eosinophils or raised exhaled breath nitric oxide. And the reason that that's a useful biomarker is that exhaled breath nitric oxide is mediated specifically by interleukin-13, whereas eosinophils is mediated by interleukin-5. They also have a license indication for atopic dermatitis, and they will probably be another 6 to 12 months get a license indication for nasal polyposis as well. Very effective in both conditions. Very expensive, like anti-IL-5 and anti-IgE, and again, they're effective at reducing exacerbations and oral steroid sparing, but unlike anti-IL-5, they're much better at improving lung function. And that's because interleukin-13 is involved in regulating airway smooth muscle activity, whereas interleukin-5 isn't. The beta agonists, I'm not going to go through the pharmacology. You've already been taught that. They work on membrane-bound beta-2 receptors, mostly on airway smooth muscle. There are some beta-2 receptors on inflammatory cells like mast cells, but we're talking about really the effect on airway smooth muscle. They stimulate airway smooth muscle receptors, which releases cyclic AMP, and that's the final common mediator in producing smooth muscle relaxation. We can divide them into short and long acting. Short acting is salbutamol, which is the one that's commonly used as a reliever, the so-called blue inhaler. And the long acting drugs are given either twice a day, namely salmeterol or formoterol, or once a day, indacaterol, vilanterol, and olodaterol. If you're going to learn about these, probably the ones you need to know about are salbutamol and either formoterol or salmeterol. You don't need to learn the once daily ones. Those are new kids on the block. There are combination inhalers. We've got an inhaled steroid and a long-acting beta agonist. One of the most commonly used is beclomethasone formoterol, which can be used with the single maintenance and reliever therapy. In fact, there's two. One is beclomethasone formoterol, and the other is budesonide formoterol. So SMART stands for single maintenance and reliever therapy. What that means is that formoterol, although it's long-acting, has a fast onset of action like salbutamol. So you can actually use it as both a reliever and a controller. So basically, the patient, when they get symptoms, they just take more doses of their beclomethasone formoterol. And it's a really good idea because it means every time a patient takes a reliever, why do they need to use a reliever? Because the inflammatory cascade is activated, which means they automatically get an extra dose of the preventer. So it always ensures the SMART regimen, perfect concordance between preventer and a reliever. So say, for example, you're on beclomethasone and salbutamol. First of all, that means you've got the hassle of two separate inhalers. And what tends to happen is that patients over-rely on their salbutamol and end up stop taking their beclomethasone. That can't happen here because the two are wrapped into the same inhaler. So what we normally say is to take 2 to 4 puffs of the inhaler as maintenance therapy, so that doesn't change, that's your background dose, and then you take extra puffs as and when you need it according to symptoms. And the clinical trials have shown that it's actually just as effective, if not more effective, in reducing exacerbations than taking a fixed dose all the time. And because you're varying the dose up and down over the piece, it means your exposure to inhaled steroid is much lower. So that's the way I prefer to use inhaled steroids now, is using either beclomethasone formoterol or budesonide formoterol using the SMART regimen. Inhaled steroids are used in asthma or COPD. They're used in combination with LABA as dual therapy or triple therapy. So they're used as both of these modalities, dual or triple, in COPD. But in COPD, bronchodilators are used without inhaled steroid. And that's a really important learning point here. We would never use a long-acting bronchodilator like LAMA or LABA on its own or in combination without an inhaled steroid in asthma. So if you're giving a LABA or a LAMA in asthma, it has to be with an inhaled steroid. Whereas in COPD, it can either be with or without. They've got a high therapeutic ratio because they're given by the inhaled route, delivered directly to the site of action. They do, however, with chronic use of LABA, they do downregulate beta-2 receptors and they uncouple the G protein adenylyl cyclase to result in what we call subsensitivity or tolerance of response. The pharmacological term is tachyphylaxis. In other words, loss of efficacy. So that is a bit of a problem. But the good news is that when you take a LABA with an inhaled steroid, the steroid counteracts that by upregulating the beta-2 receptor. So as long as you're giving a LABA with an inhaled steroid, usually this phenomenon of tachyphylaxis and downregulation isn't a problem. Usually only a problem if given alone. If you give beta agonists like salbutamol systemically, which we don't really do, then it stimulates systemic beta-2 receptors elsewhere in the body, and there are beta-2 receptors in the heart, so you get tachycardia and palpitations, and there are systemic beta-2 receptors on skeletal muscle, so it gives you the shakes. And it can also cause hypokalemia by promoting influx of potassium into skeletal muscle cells. You do see that also if you're taking high doses of beta agonists like salbutamol, that you can get some systemic effects. We tend to give higher doses of salbutamol through a device called a nebulizer when given for an acute exacerbation of asthma or COPD. And the reason we do that is because you can entrain oxygen through the nebulizer. So at the same time of giving oxygen, you can take your high-dose salbutamol. I'm not going to go over the pharmacology of muscarinic receptors. Suffice it to say the drugs I'm going to talk about, which are the muscarinic antagonists, block M-plate muscarinic cholinergic M3 receptors on the smooth muscle M-plate. That's how they work. So this is the parasympathetic nervous system, whereas beta-2 agonist is the sympathetic nervous system. So the sympathetic nervous system, endogenous adrenaline, makes your airway dilate by relaxing smooth muscle. The parasympathetic nervous system through acetylcholine makes the airway constrict. So that's why these are antagonists. When you're stimulating beta-2 receptors, they are beta-2 agonists. Okay? So we're blocking the parasympathetic nervous system, or we're stimulating the sympathetic nervous system to treat asthma. Some people call them anticholinergics because they block acetylcholine, but most people call them muscarinic antagonists because they block M-plate M3 receptors. We can divide them into short-acting, ipratropium, which have to give 4 times a day, or long-acting, probably the one to remember, the archetypal one, which has been around for probably now 15 to 20 years, is tiotropium. There are other ones which can be given once or twice a day, like glycopyrronium, umetildidium, or aclidinium. But the archetypal one, if you're going to learn one, learn tiotropium. Given by the inhaled route, they have a high therapeutic ratio, like beta agonists. They're used mostly in COPD to reduce exacerbations and improve symptoms. We're talking about long-acting muscarinic antagonists now. We only use short-acting ones like ipratropium in acute airflow obstruction. So the long-acting ones are usually given in COPD in combination with a LABA. So in other words, a dual combo inhaler, which has got a LAMA and a LABA in combination. You don't know the names of these. Or in COPD, if you want to give them with an inhaled steroid, because a patient's got ACO, eosinophilic COPD, then you would give them in combination with an inhaled steroid like beclomethasone. So that'd be a triple inhaler. We also use long-acting muscarinic antagonists in asthma. They're not used instead of LABA, so there's no ICS LAMA inhaler, but we do use triple inhalers, like this one here, like beclomethasone, formoterol, glycopyrronium, as triple therapy at step 4. So rather than having an ICS LABA inhaler, like beclomethasone, formoterol, and then adding in a separate LAMA, which would need 2 inhalers. So let's say you were on beclomethasone, formoterol, and adding in separately tiotropium, which needs 2 inhalers with 2 different techniques. It's much easier to have 1 inhaler, which has got all 3 components in it. So that's the way forward in asthma at step 4. So we wouldn't tend to use 2 separate inhalers. And as I said, we use high nebulized doses with oxygen entrained of ipratropium together with salbutamol in either acute asthma or acute COPD, because there's additive effects of salbutamol and ipratropium. We don't use ipratropium as a reliever for either asthma or COPD, only for nebulization. I'm briefly going to talk about the methylxanthines. They're not really used much. They're a sort of a hybrid drug between a bronchodilator and an anti-inflammatory, which I can see I've spelt wrong there. I'll correct that. The archetypal one is theophylline, which is given orally. It's used for maintenance therapy. Tends to be used more for asthma than in COPD. It's a slow release formulation, which releases slowly into the blood, which can be used for nocturnal dips. So if you take the tablet at night, You've got some in your blood to cover that dip throughout the night and early morning. They're never used on their own, only used as add-on to inhaled steroid. We can give a diamino ester formulation of theophylline called aminophylline intravenously for acute attacks of asthma. So if the patient's already had nebulized salbutamol and ipratropium and they're still constricted, we might give them IV aminophylline. They work because they're non-selective inhibitors of phosphodiesterase, so they increase cyclic AMP, and they also block adenosine receptors on inflammatory cells as well. They have a low therapeutic ratio, whereas the dose which gives you therapeutic efficacy is very similar to the dose which gives you side effects. And the main side effects, because they're systemic, is they make you feel nausea, they can give you headaches, they can give you a tachycardia, and give you the shakes. And they do have interactions via hepatic liver cytochrome P450. So if you're on a drug like erythromycin, which blocks P450 metabolism of theophylline, it can increase your theophylline levels and give you theophylline toxicity if you don't alter the dose. So they're used mostly in asthma as maintenance therapy, and to a much lesser degree in COPD. In fact, hardly used in COPD at all now. If you want to give a phosphodiesterase inhibitor for COPD, then this is the one you would use. So these are phosphodiesterase type 4 inhibitors. So theophylline is a non-selective phosphodiesterase inhibitor, and roflumilast is a selective inhibitor of phosphodiesterase type 4. So if you like, it's sort of designer theophylline in a simple way. It's given once a day. It's only indicated for COPD, not for asthma. Doesn't really do much for FEV1. It's mostly anti-inflammatory, and it reduces exacerbations. It's only given additive. You would never use it on its own. It's only given additive to either LABA/LAMA or a triple inhaler. Okay. Problem is it does have similar side effects to theophylline: nausea, diarrhea, headache, and weight loss. And that's why it's rarely used. Mucolytics, not really used very much, to be honest with you. Examples are carbamazepine and erdosine. They reduce sputum viscosity and aid expectoration, production of sputum. There is some data showing they can reduce exacerbations, but they're rarely used. They're not very effective. You would only ever use it, say, as add-on to triple inhaler therapy in COPD. So let's just tie things up then. The treatment of chronic persistent asthma, the aims are to abolish symptoms, minimize reliever use with short-acting beta agonists, normalize FEV1, reduce peak flow variability, reduce exacerbations, and prevent airway remodeling. We should try and avoid trigger factors where feasible, suppress the inflammatory cascade with inhaled steroid, melt away the eosinophils, and then add in either non-steroidal anti-inflammatory therapy with leukotriene receptor antagonist, theophylline or chromoglycate, or more commonly, stabilize airway smooth muscle with a long-acting beta agonist and or a long-acting muscarinic antagonist. So you give an ICS-LABA or an ICS-LABA-LAMA triple inhaler. Treatment of acute asthma, we never use inhaled steroids to treat acute asthma. Really important learning points. You either give it orally, this is the systemic route of administration, going straight into the blood, or you give it intravenously. The oral steroid is prednisolone, and the intravenous steroid is called hydrocortisone. In addition to giving systemic corticosteroids, we give high-dose inhaled through a nebulizer with oxygen. We give salbutamol, usually with ipratropium, and if that doesn't work, we can give intravenous aminophylline or intravenous magnesium, which is a bronchodilator, relaxes airway smooth muscle. You give at least 60% oxygen. I'm not going to go into oxygenation. Tom Farder will tell you all about that. And finally, if patients don't respond to all of that, then we would intubate them and give them assisted mechanical intervention if they can't maintain their blood gases. In other words, if the PO2 was falling and the PCO2 was rising. Tom will tell you more about that, so don't worry about that. Moving on to the treatment of COPD, the aim is mostly to reduce exacerbations, improve symptoms, try and improve lung function, and prevent the onset of pulmonary heart disease, hypoxic pulmonary vasoconstriction. So stop smoking at any stage, immunization, drug treatment, and pulmonary rehab, and if necessary, long-term oxygen. This slide just shows you the reason and the rationale why it's important to stop smoking at any age to prevent further decline in lung function. So we've already talked about the non-pharmacological management. So now I'm going to focus more on the pharmacological management. And the pharmacological management is quite simple, is if you are non-eosinophilic, if your blood eosinophils are less than 300 per microliter, then you would go onto LABA-LAMA combination. And if you are an eosinophilic frequent exacerbator, then you would take an inhaled steroid, either with a long-acting beta agonist alone, or in combination with a long-acting beta agonist and a long-acting muscarinic antagonist. So those are the three types of drug, depending on whether you're eosinophilic, in which case you don't take an inhaled steroid, or if you're an eosinophilic frequent exacerbator, then you would take an inhaled steroid. Flumalast, which I've put in italics and green, because we don't really use much, only used as add-on to either LABA-LAMA or triple therapy. Mucolytics, not used much. We do sometimes use long-term azithromycin to cover the winter months, especially patients who've got, for example, bronchiectasis as well as asthma, or bronchiectasis as well as COPD. And we give a low dose 3 times a week. So this is a figure which I produced for the Lancet Respiratory Medicine, showing the rationale for treating patients with COPD. So if we just forget Gold C, because there's hardly any Gold C patients, they just asked me to put that in. So let's just talk about Gold D, who are frequent exacerbators with lots of symptoms, or Gold B, these are patients who are infrequent exacerbators with lots of symptoms. So these are the two main groups, Gold B and Gold D. So the first thing that you should assess is whether they're symptomatic and whether they exacerbate. And this is a definition of a frequent exacerbator. 2 or more exacerbations a year, or someone who's been in hospital with an exacerbation. You don't know this, it's just for information. So we would do a blood eosinophil count. If the eosinophil count's more than 300, then we would put them on a triple inhaler with ICS LABA-LAMA. And you might be thinking, well, why not just put them on a LABA-LAMA? On an inhaled steroid with a LABA. And the reason for that is that 2 bronchodilators are better than 1. So that's why we tend to use triple therapy now rather than ICS LABA. And all of the clinical trials have shown that triple therapy with inhaled steroid is better than dual therapy with inhaled steroids. So that's why triple tends to trump ICS LABA. If the eosinophil count's low and they're symptomatic, then, or if they're a frequent exacerbator, then we wouldn't use an inhaled steroid, we'd go on to LABA-LAMA dual. And you might be thinking, well, why not just put them on a LABA and LAMA alone? And that's because all the clinical trials have shown that dual long-acting bronchodilator is better than single agent alone. I've put here that at this point here is that if your eosinophils are more than 300 and you're an infrequent exacerbator, there may be a role for ICS LABA, but that's pretty small print, to be honest with you. So where do you use inhaled steroids in COPD? This is important to know, so listen up. We'd use it in infrequent exacerbators who are non-eosinophilic. In that case, we wouldn't use an inhaled steroid. So if you're non-eosinophilic and you don't exacerbate, equals no inhaled steroid. If you are an eosinophilic frequent exacerbator, then we would tend to use a triple inhaler because you've got the 2 bronchodilators are better than 1. So triple therapy in this phenotype trumps dual therapy with ICS LABA, and certainly trumps dual long-acting bronchodilator therapy, LABA-LAMA, without an inhaled steroid. So most patients with this phenotype, the eosinophilic frequent exacerbators, would go onto a single triple inhaler. Something to bear in mind is that all inhaled steroids do have a small increased pneumonia risk as a class effect, and those which are lipid-soluble lipophilic have the greatest risk because they hang around in the lung for a long time and produce more sustained immunosuppression. So easy way to remember that the ones which are lipophilic is beginning with the letter F, fluticasone furoate, FF, or fluticasone propionate, FP. The ones which are less lipophilic begin with the letter B, namely beclomethasone or budesonide. So if you're prescribing an inhaled corticosteroid in COPD, the easy way that I remember it is never use the F word, only use the B word. B word, beclomethasone, budesonide. F word, fluticasone, furoate, fluticasone, propionate. Treatment of acute COPD, pretty much like acute asthma, is that we give them high-dose salbutamol and ipratropium. We tend to give most of them prednisolone, even if they're not eosinophilic, just to cover our bets. But strictly speaking, you should only give it to eosinophilic COPD patients. But it ends up being given to most. We give them an antibiotic because most of them have got an infection, usually Haemophilus. So we give them amoxicillin or doxycycline. We give them oxygen titrated against their partial pressure of oxygen and partial pressure of carbon dioxide. Tom will tell you more about that. We use physio to try and get the sputum up. And we don't tend to invasively, mechanically intubate and ventilate them. We tend to use non-invasive ventilation. And that permits us to get away with a higher inspired oxygen level. And Tom will tell you more about that. So that's the end of the slideshow. Thanks again for paying attention. And hope you have a good day.